and welcome to the ACR Journals on Air podcast. I'm your host, Vicky Shamagam. Today's episode highlights one of the sessions being held at ACR Convergence 2025. The session we will discuss today is Updates in Pulmonary Hypertension, the personalized approach to screening for pulmonary hypertension in connective tissue diseases. I'm pleased to be joined by Dr. Kristin Hyland, who will be leading this session. Dr. Hyland is Professor of Medicine at the Cleveland Clinic Lerner College of Medicine at Case Western Reserve University and Vice Chair for Research of the Integrated Hospital Care Institute. She is board certified in internal medicine, pulmonary disease, critical care, and rheumatology. And her clinical and research focus is on the pulmonary manifestations of rheumatic diseases, with particular emphasis on interstitial lung disease and pulmonary hypertension in scleroderma. Her research spans translational studies and multinational clinical trials aimed at improving the understanding, diagnosis, and treatment of pulmonary vascular and interstitial lung diseases associated with systemic autoimmune rheumatic diseases. She has led and contributed to pivotal trials in pulmonary hypertension and systemic sclerosis-associated ILD, while also advancing biomarker discovery and patient-centered outcome measures and registry-based research. Dr. Hyland serves on the Scientific Steering Committee of the Pulmonary Hypertension Association and on the Medical and Scientific Advisory Board of the Scleroderma Foundation. And her combined training has given her a unique perspective and expertise in caring for patients with rheumatic lung disease and pulmonary hypertension. It is truly a pleasure to have her on the podcast today. Welcome to the show, Kristin.
Thank you so much, Vicky, and thank you for such a kind introduction. It's really a pleasure to be here. I'm excited about the session I'm going to give because pulmonary hypertension and connective tissue diseases is so challenging, and I feel like it's an important area because, particularly in scleroderma, this is a population that we can detect early and intervene early. And I think it's important to also recognize that pulmonary hypertension in the setting of connective tissue disease is different than that of the patient with idiopathic pulmonary arterial hypertension due to the systemic nature of connective tissue diseases. And so I believe we're really starting to see the value of tailoring our approach to the individual patient with an underlying connective tissue disease.
Now, that's great. I am really thrilled that you're doing this session and kind of interested to know what inspired you to focus on this personalized approach to pulmonary hypertension in connective tissue diseases, and why is it so critical to kind of shift towards this personalized medicine approach?
Because I don't think one size fits all. I think patients with connective tissue disease are different than patients with idiopathic pulmonary arterial hypertension. And I think one connective tissue disease is different than the other. We see this with looking at pulmonary hypertension in patients with lupus versus those with scleroderma. In lupus, pH can be a presenting manifestation. Rarely, but it can occur. And it sometimes can respond to immunosuppressive therapy. This is not the same for scleroderma, where pulmonary hypertension is more likely to occur later in disease. We have no evidence that immunosuppressive therapy would be an adjunctive treatment in scleroderma. So there's difference in risk factors, there's difference in timing, there's difference in clinical course. For instance, pulmonary hypertension in lupus has better survival outcomes than pulmonary hypertension in scleroderma. I believe there's different underlying mechanisms. The pathobiology behind our various connective tissue diseases is different. We also know that pulmonary hypertension is very messy in CTD. pH doesn't fit in one category. Patients may have pulmonary arterial hypertension. They may have group 2 from left-sided heart disease or valvular involvement. They may have group 3 pH from interstitial lung disease, which is also very common in CTDs. Or they could have group 4 pulmonary hypertension related to chronic thromboembolic disease, especially in those patients with lupus anticoagulant or antiphospholipid antibodies. And we're also recognizing the increasing frequency of group 1 pulmonary veno-occlusive disease, where there's both arteriolar and venule involvement. And those patients can be particularly challenging to take care of and are likely underdiagnosed, particularly in scleroderma. And what's even more complicated is all these groups overlap. So patients can have features from one group and a different group, which makes them more challenging to phenotype and to come up with a treatment strategy. So as we get better tools, imaging, biomarkers, information from registries, I think we can move beyond blanket algorithms. We can properly phenotype each patient, and this precision will allow us to tailor our therapy and to identify patients earlier based on the underlying mechanism of their pulmonary hypertension.
So as you explained that, it seems such a complex matrix to put all of this together. How are you as a clinician scientist approaching this concept of personalized diagnosis and management in the context of screening and diagnosis for these diseases? Are you focusing predominantly on biomarkers, imaging, clinical phenotype, or do you have some secret sauce that ties all of those things together?
I think the secret sauce is to tie everything together. Even before advanced diagnostics and movement into the world of omics, there has been very clear recommendations by our different societies, whether it's the European Respiratory Society, the European Society of Cardiology, or EULAR and ACR, to really use a multimodal approach to taking care of our patients. We never want to make a decision based on one value. So to me, this personalized approach encompasses many layers. Is not just about biomarkers. It's not just about imaging. It's about integrating the whole patient's story, their disease phenotype, their autoantibody profile, their comorbidities, their functional status, their patient-reported symptoms, and then adding on objective measures such as echocardiography and pulmonary function trends or novel blood-based markers. So to me, personalized medicine means weaving all of that together into a composite risk profile instead of relying on a single test or a rigid threshold. And I also think the patient perspective, incorporating the patient perspective is so important. And that was actually a working group at the last 7th World Symposium on Pulmonary Hypertension to include the patient perspective, how the patient experiences their disease, what symptoms are most mattering to them. Because at the end of the day, that's what truly makes it personal.
Right. And that's what improves lives as well and living with these diseases. So I wonder, in this world of emerging technologies and particularly AI-assisted imaging and diagnostics, how do you fit those into this personalized screening landscape?
Well, we're early at that. There are big challenges in that some of these rheumatologic diseases are very rare diseases, and then layer on pulmonary hypertension, which is also very rare. And so it's it's often not top of mind. And so there's delay in diagnoses. The symptoms of pulmonary hypertension are very nonspecific. Sometimes they're attributed to other aspects of connective tissue disease, blamed on shortness of breath can be interstitial lung disease or fatigue or being deconditioned or the rheumatic disease itself. And common things being common, patients are still being mislabeled as having asthma or COPD or heart failure or deconditioning. Sometimes patients don't even realize they're short of breath because subconsciously they've made their world smaller to avoid symptoms, or their activity is already limited by arthritis or muscle weakness. And then on top of that, access is a major barrier. Not all patients are followed in specialized centers. Screening programs are not consistently implemented. In many community settings, echocardiograms don't focus on the right side of the heart, right side of morphology and function, which is the end stage consequence of pulmonary hypertension. And then there's a shortage of rheumatologists. And so often in clinic visits are consumed by urgent issues like joint pain or muscle pain or rash or fatigue. And there's not always enough time to perform systematic screening for pulmonary hypertension in the course of a typical appointment. But we know that pulmonary hypertension is relentlessly progressive. Another challenge is that the diagnostic threshold of pulmonary hypertension has been lowered to a mean pulmonary pressure greater than 20 millimeters of mercury, which is appropriate because people with higher pressures have poor outcomes. But that also means that the earliest stage of disease, there may be very few clues. Patients might not have symptoms if they're not active. They might not have exam findings. The echo might look normal. And all of this non-specific symptoms, mislabeling, access barriers, workforce shortages, and limitations of our tools contributes to delayed diagnosis, and too often patients present only once their disease is advanced. We are very early in trying to use omics and radiographic changes and EKG changes and echo changes using more advanced techniques like AI to help personalize this, but this is still very, very early.
Yeah. I mean, many of those models are built on pattern recognition, and one of the challenges is being able to train those models to recognize the patterns early enough to impact disease progression, I guess.
Absolutely.
So are there any specific red flags or subtle clinical signs that you as a pulmonary hypertension specialist think rheumatologists should be more attuned to when they're evaluating people at risk for pulmonary hypertension?
Absolutely. A decline in diffusion capacity, especially when the forced vital capacity is stable, could be an indicator of pulmonary vascular disease. Think of diffusion capacity as a kind of a crude biomarker of the integrity of the pulmonary vascular bed. A poor 6-minute walk distance, and we recognize that 6-minute walk distance could be limited in our CTD patients because their ankle hurts or their foot hurts. And so there might be non-cardiopulmonary reasons to have a low 6-minute walk. However, if you're looking at that walk and you're seeing abnormal cardiovascular response to exercise, blood pressure's dropping instead of going up, heart rate's getting very, very high and slow to recover, or there's oxygen desaturation, in addition to distance, that can be a warning sign. I'd like to pay specific attention to syncope or near syncope. Patients might say dizziness. This is an extremely concerning symptom. It can be associated with a very poor prognosis and is likely underfilling of the left ventricle due to a failing right ventricle. And patients with syncope should have, that's a later finding, and that should result in an expedited evaluation for the possibility of pulmonary hypertension. Of course, if you're doing your exam and you hear an increased P2 or lower extremity edema, those are signs the right ventricle is failing. An early test is NT-proBNP. You can throw that on when you're getting your regular labs on your patients. An elevated NT-proBNP indicates ventricular strain. It can be elevated due to left-sided disease, but also right-sided disease. And it can go up as one of the earliest signs before patients even have symptoms, before you see changes on echocardiography. So I would just encourage rheumatologists to kind of pay attention to, a mismatch when symptoms and functions seem worse than you would expect, especially from any underlying interstitial lung disease or the musculoskeletal symptoms alone. That's when you should be thinking about pulmonary hypertension.
Yeah, really good tips. And thank you for sharing that. How do you see the collaboration between rheumatologists, pulmonologists, cardiologists evolving to support these more individualized care pathways?
Collaboration is so important. And I don't think any specialty owns pulmonary hypertension. It differs across our country. Some pulmonary hypertension programs are run by pulmonologists, others are run by cardiologists, but irregardless, both are really necessary to completely evaluate a patient thoroughly and treat them. And of course, we need the rheumatologist to help identify these patients who are at risk and to help manage the non-cardiopulmonary things that are going on associated with connective tissue disease. And without, a careful collaboration, we can't provide the best care for our patients. And so many programs already have multidisciplinary clinics that include pulmonologists, cardiologists, and rheumatologists. And those clinics really do provide better outcomes, better diagnoses for our patients. In fact, sometimes, and I don't have to tell you this because you're a rheumatologist, connective tissue disease can be subtle. And I get referred patients who are labeled idiopathic, and on further evaluation, they actually have, a subtle underlying connective tissue disease. And without the rheumatologist expertise, we're missing those diagnoses.
Yeah, no, and as a clinician, I remember seeing patients referred by pulmonary and cardiology who, their autoimmune disease was really picked up by the cardiologist or the pulmonologist. And so definitely that can happen, and we've all seen it. You touched on this earlier, but I'm wondering for you as a clinician, how much emphasis do you place on the patient-reported symptoms and on monitoring those symptoms over the long term? So this kind of longitudinal monitoring, and how important is change over time in refining diagnostic accuracy?
I think the patient voice is so critical. Patients sometimes notice subtle changes that, just aren't picked up on by, current available tests. I'll share, I have had two patients with that are elite athletes that also have scleroderma, who are, one of them in particular was number 7 in the entire world in her sport.
Wow.
So by anyone's opinion, she's healthy. She's winning things in her sport and exercising like crazy and looks healthier than the rest of us. But, she would say, my personal best time is down by 20 seconds. And sure enough, it was like the earliest sign of pulmonary hypertension. So that would have not been, there'd be no medical test that would have picked that up. So patients, they know their bodies. Patients are experts on their bodies. And I also think incorporating the patient, using digital health tools, we're all wearing our Apple Watches and our Fitbits and whatnot. With advances in those technologies, we can possibly pick up subtle changes. A number of years ago, I worked with a fellow that was interested in accelerometry. He used the Fitbit to try to compare steps walked with, more traditional pulmonary hypertension endpoints. And we could see with a couple of our patients that were wearing a Fitbit that, we saw that their average steps were starting to go down, and that actually predicted a hospitalization.
Interesting.
And what was interesting, we were looking at the steps, aggregate steps, like how many steps per day. Some bioinformatics people from Johns Hopkins looked at our data and wanted the second by second data to see heart rate variability and things like that, and actually published an interesting paper in Nature of Digital Medicine based on that data and correlations with disease severity. So I think it's so crude when our patient just comes to clinic every 3 or 4 or 6 months. That's a long period of time that we're missing an opportunity.
Yeah, even the 6-minute walk test, I feel like sometimes can be less accurate because it's an artificial setting. People may under or overperform based, as opposed to their baseline. And I've always kind of thought it was a very crude measure.
It is a crude measure, and patients can just have a bad day. They can, have already walked from the parking lot to the echo to the CT place. Now they're in clinic, they're exhausted, they don't have the right shoes on. There's people moving in and out of the hallway, getting in their way. There's so many things. And maybe that day, their knee is bugging them. So we don't know always what that 6-minute walk test is measuring. Fortunately, there's a lot of different data points besides distance that we can lean into, but it is exercise capacity, which is different than activity.
Yeah. So I'm going to ask you to speculate a little bit on sort of future and how do you sort of seeing this evolve and having been obviously very involved in some of this research, how do you envision these personalized strategies potentially influencing future guidelines and future screening algorithms and wearables the way of the future?
Well, I think they're a component. I also think they're, you know, using artificial intelligence to, do machine learning to, look at things on echo or vascular things on CT scan that maybe the human eye can't pick up alone. We're involved in a study that is looking at EKGs to see if there are things on the EKG that, a computer can detect to identify patients earlier than later with pulmonary hypertension. The NIH has been trying to solve this, and they funded a program called PVDomics, which was designed to really deeply phenotype patients, on an endophenotypic level. So based on, all the typical clinical tests, patient reported outcomes, PFTs, imaging, and then patients were also getting, proteomics and genomics and, all the different omics to try to kind of blow up the current, we have 5 types of pulmonary hypertension system because most patients don't read the textbook and, they're somewhere between, they might be a big 1 and a little 3 or a big 3 and a little 1. And right now that's sort of the art of taking care of pulmonary hypertension. But with PVDomics, we're seeing these clusters that are, hopefully one day going to help say, okay, you in this particular cluster would benefit from this therapy. And so, I think it's coming. I think we have a whole lot to do before we can really say we're doing personalized medicine. But I think, using a multimodal approach where we're using every bit of data that we can get from an individual patient that we currently have access to can really help inform, our strategies. And hopefully that will then evolve into better guidelines that are, addressing the nuances of care. And I think it's really important when we're thinking about connective tissue disease patients compared to idiopathic patients. In 2022, it's been well established that patients with pulmonary arterial hypertension should be on combination therapy targeting the endothelial pathway, the nitric oxide pathway, kind of out of the get-go. And that was based on the AMBITION study. And in 2022, they backed off and said, well, if you have a comorbidity, maybe you should think about monotherapy, which actually was those recommendations were sort of a disservice to patients with pulmonary arterial hypertension, particularly connective tissue disease, because then they weren't being aggressively treated with multiple pathways. And so the latest World Symposium in last year kind of reversed that recommendation and, recommends, upfront combination therapy for pretty much all our PAH patients, whether they have connective tissue disease or not. But I do think as we are treating our connective tissue disease patients, because pulmonary hypertension is so messy, that applying an algorithm that makes more sense for idiopathic pulmonary arterial hypertension is probably not doing our CTD patients justice. And I think there's still work to do in that space.
Yeah, and I appreciate you saying that. And, many folks who attend ACR Convergence, they're rheumatologists, they're practicing in busy clinics. For the clinicians attending your session, what practical tools and practical insights do you hope that they're going to be taking back to their practice from your talks?
So I hope that they remember, red flags. So when to think about pulmonary arterial hypertension, that it can, be front of mind inappropriately. I hope that they come away with a strategy for integrating various data points so that they're not just relying on one test. The echo could be helpful when it's abnormal, but sometimes not helpful when it is normal. How do you maintain that high index of suspicion? And then, of course, confidence to advocate for their patient and to collaborate across specialties with, pulmonary and cardiology, and to build that system so that they can best take care of their patients in their own practices.
Spectacular. And I can't wait for your session. I'm really looking forward to it. And I really appreciate you sharing your expertise with our rheumatology community. I wanted to change direction now and ask you a couple questions about your journey through your career. You are unique. It's relatively unusual, I think, to have such incredibly specialized training. You specialties, internal medicine, rheumatology, pulmonary, and critical care. What drew you to all of these areas, and how has your clinical focus evolved over the years?
So I didn't seek it out. I think it seeked me out. I just went with the flow. When I was in college, my girlfriend convinced me to ride my bike from Chicago to Michigan City, which is 100 miles. I rode my bike that I had in sixth grade that I bought with my paper route money. And that was for one of the first fundraisers for the Scleroderma Foundation. I had no clue what scleroderma was at the time. And then when I was in medical school, my next door neighbor's mother had scleroderma. When I bought my first house as a pulmonary fellow, my next door neighbor's father had died from scleroderma renal crisis. It's kind of like it was following me. And then I got interested in interstitial lung disease and pulmonary hypertension as a pulmonary fellow. And I had a lovely mentor, Charlie Strange, who kind of filled that niche. And he was very involved in the scleroderma lung study #1. And so I saw that a lot of his patients had an underlying connective tissue disease, particularly scleroderma. And I trained in Charleston, where at the Medical University of South Carolina, that has a very strong scleroderma center. And we shared clinic space. So rheumatology was down one hallway and pulmonary was down the other. And we had a conference room and we were rubbing elbows and learning from each other. It was like hard not to get interested. And then I met, Dr. Richard Silver, who was chair of rheumatology at the time, who, just became a mentor of mine and just is still a mentor of mine. And has influenced the way I think about patient care and research and collaboration. So that's kind of how I got interested. I had to convince Dr. Silver to take me as a rheumatology fellow. I had to ask him 3 times. He kept turning me down. He eventually said yes. And I'm very grateful for, my unique training. It's really opened up some doors and has taught me to think differently. I think rheumatologists and pulmonologists use different sides of their brains. Pulmonologists are sort of physiologic, and rheumatologists, are into their cytokines and chemokines and antibodies. And, kind of marrying those sides of the brain has been a lot of fun for me.
Oh, that's amazing. And I am so touched that you share that whole story, because you're right. It sounds like the universe made this disease find you. And that is so heartwarming to hear. So I'm wondering, you talk about Richard Silver, an amazing rheumatologist. Were there any other mentors or role models who influenced you on your path? And what qualities do they embody that you now try to pass on to others?
You know, another person that was very pivotal in my life is Mark Judson. He's a pulmonologist. He was in Charleston. He's currently chair of pulmonary in Albany, New York. And he's kind of famous for sarcoidosis. And so when I think of him and Charlie Strange, and I think of Dr. Silver as mentors, first of all, they are experts in their field. So the three of them just have their own personal legacy as experts, which I think is important for a mentor. But even more important, they gave. And I think their success was almost based on promoting people underneath them. If Dr. Silver got asked to speak at a conference in Europe, he'd say, "Okay, I'm happy to speak. Can my fellow Kristin speak also? She would be good to give a talk on such and such topic." And he would drag me along, and I'd have these wonderful opportunities to go to these meetings I wasn't ready to be invited to on my own. And Dr. Judson and Dr. Strange, when I would go to the American Thoracic Society, I'd be like a barnacle to them. I would just be attached, and they would introduce me to the movers and shakers in the field. And, they just promoted me, which was really great. They also parented me. And so when I was misbehaving or coming up with idiotic ideas, they let me know it. And they helped, kind of keep me on task. They let me fail. They let me be creative, but they encouraged me. And I am so grateful, incredibly grateful for my mentors.
Oh, that's amazing to hear. I'm wondering, as a mentor now yourself, how have you been trying to guide early career clinicians, researchers, and people who, like you, are finding that this disease is seeking them out and are trying to find their way?
I try to remind them that, I have to do this with my own daughter. I had my daughter when I was 40, and it's just the two of us. And, she thinks she should be my peer. And I'm like, I have 40 years on you. And so, I think early on, particularly it's like your career is so linear. It's like, you have to study to get into college, then you have to study to get into medical school, and then you have to be fantastic so you can get a residency, and then fantastic to be a fellow. And so it's very clear that it's linear. And then all of a sudden you've sort of arrived and the world is your oyster. And you're like a kid in a candy shop, and it can almost be paralyzing. But that is like fun. And then your path becomes completely non-linear, and it takes forever. It takes 40 years to get where I've gotten. And you have kids and you do a project and it's a big flop, and you have all these failures that you learn from, or you all of a sudden get interested in this other thing and hear, opportunities to kind of take a winding path. And that becomes so exciting. So I tell my mentees, you don't have to accomplish everything tomorrow. And in fact, everything's going to take like 10 times longer than you could possibly imagine. So be patient with yourself and give yourself permission. As a single mom, when I had my daughter, there's a 3-year gap in my CV that if you look for,
Yeah.
you can see. But that's okay. That time was very important as a new mother. So it's okay to have your own timeline and to follow your zigzaggy path. Nothing's a prison sentence. And in fact, you might, I did a little bit of basic science. I found that I didn't particularly care for it. I love people that do basic science so that I can partner with them, but I don't have the patience to pipette. So I learned that about myself, but I also learned a lot of cool basic science stuff that is really interesting. And I don't regret that time for a minute. And, I think I like the fact that, because I hang out with cardiologists because I do pulmonary hypertension, and I'm a pulmonologist, and I'm a rheumatologist. I get all these different perspectives, and it makes me more creative. So, I try to encourage them to be creative. I try to encourage them to find their passion, their reason for being. But I also try to help them be resilient, because everybody's going to fail, particularly if you're doing research. My boss's boss, who's like famous, he's like, yeah, my first 13 grants did not get funded. You have to have that resilience, but you always learn. You learn more from things that don't work out the way they're supposed to be than things that do work out. And then the last thing I learned, when you're applying for medical school and that competitive residency or fellowship, you become competitive, and me oriented. It's like, what do I have to do to beat out the other person so I can get that slot? But when it comes to research, it really is a team sport. When it comes to taking good care of a patient, that's also a team sport.
Yeah.
And so, leaning into collaboration so that you're not afraid of complexity is really key. And you know what? Patients like that. They like seeing that you're talking to, the other doctors and everybody's staying on the same page. Patients like collaboration, and, and you're going to be more successful with research if you're working with other people. So,
yeah, I mean, I really thank you for sharing that advice. I feel like it's so important no matter what the specialty, but especially important for specialties like rheumatology and pulmonary, where there's so much overlap and so much collaboration that's needed.
Absolutely. Love makes the world go around.
It's so true. So I want to thank you, Kristin, for joining us today and for sharing all these insights with our listeners. We're so grateful for the work that you do in this field and for the work that you do mentoring others. A shout out today also goes to pulmonologists and cardiologists who help us advance the science of pulmonary hypertension, benefiting many patients with connective tissue disease. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at AC Rheum on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.